everyone, and welcome to this question and answer session on infertility. We have with us infertility expert Dr. Navdeep Singh Pannu, who is a medical director and consultant obstetrician, gynecologist, and fertility specialist at TMC Fertility Center and Thomson Hospital. He has received his specialty training at the University of Malaya and in the United Kingdom, where he was awarded the prestigious Royal College of Obstetrician and Gynecologists membership. Welcome, Dr. Navdeep. We are now honored to have you with us today, and I am excited to start with this question and answer session.
Thank you.
Hello. My first question I would like to start with. This is about this current pandemic. How the COVID-19 pandemic has altered the infertility treatment. As a clinician, how you have modified your routine practice during this pandemic?
Well, the COVID-19 has definitely caused quite a lot of havoc in the whole world. And similarly, in Malaysia too, we've been having quite a bit of these cases. And certain centers have opted to, initially, when the pandemic broke out, to close their centers or reduce their workload. In our centers, what we have done is that we remain open for business and we continue treating our patients. Because if you were to close and stop fertility treatment, then patients will get frustrated and delay their treatment. As you know, as they get older and older, they lose their fertility potential. So, end of the day, we decided to open. However, we had made a lot of precautionary action, and safety was paramount. So, what we do is every patient before any procedure, for example, like egg retrievals and all, they're required to do the COVID testing, and with a negative report, then we'll proceed with treatment. Any patient who comes in the clinic will have to call in to make an appointment, and by doing so, we were able to space out the appointments and prevent overcrowding in our clinic. All the patients will be required to take their temperatures when they come in and fill up the questionnaire regarding recent travels and whether or not they have any upper respiratory tract infection symptoms. As for our staff, what we did was our staff too will have to take their temperature whenever they come in and have to notify the management straight away the moment they have any symptoms. And if necessary, we'll do the COVID test. And we also have made it mandatory for our staff, even us doctors, to dress with a certain amount of protection. For example, either with goggles or with 3-ply mask, or even can opt for a face shield, and to wear a water-resistant gown to protect ourselves in case that we have a COVID patient. So, in short, with all these precautions that we have taken, I'm sure that both the patient and the staff will remain safe.
Very well said. I think everyone is practicing the same in their IVF centers. Now, Dr. Navdeep, IUI is often considered as the first line of treatment, and it is often seen that the multiple cycles of IUI are done in a women with advanced age or sometimes with severe male factor infertility without much success. So I would like to know that what factors are considered to decide whether the IUI or IVF should be the recommended treatment option for a couple?
Well, first of all, we have to make it clear as to why we want to do an IVF. There must be certain criteria, certain pre-procedure tests that the patient have to go. Example, we have to do the sperm analysis. If the sperm count is poor, we have 1%, even or less, or 0% morphology, then we know for sure that the IUI will most likely won't work. Then we have to opt for an IVF instead. Secondly, the prerequisite will be to do the hysterosalpingogram or any test to assess the fallopian tubes. If the tubes are blocked, I know for sure they're not going to succeed. So I've noticed a lot of certain centers where they proceed to do an IUI without a fallopian tube assessment. But I think that would waste both time and money of the patient. So severe male factors, and I would not recommend an IUI. And as for advanced maternal age, well, we can consider doing an IUI for them if they have at least one patent fallopian tube and they respond to gonadotropin and injections, follicular-stimulating hormone injections. If they respond and the sperm sample is adequate, that means above average, then I see no reason why we shouldn't offer them the procedure. But there must be a certain amount of attempts which we do, which we give them. For example, either 2 or 3 attempts and then need to stop. Because repeating more than 2 or 3 attempts, both the patient and the doctor will get depressed.
Very well said. So the prerequisites for IUI are the tube test by HSG or laparoscopy sometimes, and the basic semen analysis. Is it?
Yes, definitely.
Yeah.
And not forgetting the other issues. For example, any underlying medical issues, diabetes, hypertension, all those things have to be treated too. Then I'm sure that they have a better chance for a successful, healthy pregnancy.
Yeah. Sometimes the clinician observes the poor endometrial lining during an IUI cycle, especially in PCO patients. So what would be your recommendation to overcome this issue?
Okay, poor endometrial lining is definitely a frustrating finding in our practice, both in IUIs, IVFs, or even with patients who are just given clomiphene citrate. So number one, clomiphene citrate itself have been noted to have an increase in chance of having a thin endometrial lining. So in those kind of scenarios, then I would change them to either aromatase emitter, letrozole, or add the follicular stimulating hormone injections instead. The other thing would be when we see a patient with thin endometrial lining, we have to find out the reason why they're having it. There may be 3 main issues. One, maybe the estradiol level in their body is low. Okay, and those are generally seen in patients with a poor ovarian reserve. In those kind of cases, what I'll do is, if they have certain number of eggs growing, then I'll give them some form of estrogen supplements, tablet Progenova, estradiol, valerian, and to help to increase their womb lining. Secondly, about the issue about blood supply to the uterine cavity. Well, certain studies have said that you can do Doppler studies, but I think that's just more experimental rather than normal clinical work. And those kind of scenarios, well, they give them a trial of baby aspirin at least 75 to 150 milligram. We have tried transvaginal Viagra, okay, to help to increase the womb lining. The other issues is that you might opt to do a hysteroscopy to have a look at the womb lining. They may have scarring or other issues which may have caused their womb lining to be non-reactive. So if they do have an abnormality, then you might want to remove that first. So that's what I will do. I would basically, in summary, I would increase the medication, like the injections, FSH injections, and try aspirin and estrogen tablets. That would be my first line of action on this kind of patients. And of course, change it to letrozole if they were on clomiphene citrate.
Okay. My next question is, I wanted to ask that how to prevent multiple pregnancy and also hyperstimulation in cases we are doing IUI to a PCO patient.
Well, Well, these PCO patients tend to have a very good ovarian reserve, so some of them may be over-responsive to the medication. So what I generally do is, at the initial onset, I will try them. I'll put them on tablets, like clomiphene citrate or even letrozole, for about 5 to 10 days, and monitor the growth of the eggs. And if they do not respond well, then I'll add in the injections, the gonadotropin injections at the lower dose. For example, you can start at 50 international units per day, or sorry, alternate day instead. And I'll generally observe them. I'll tell them to come back to the clinic to do an ultrasound scan around the 10th day of their cycle. And then again, if they have no response, then I'll add an injection. And again, I'll tell them to come back about 5 to 6 days later. And I'll gradually step up the medication and observe the growth of the eggs. So rather than starting a higher dose at the initial stage, that will most likely cause the ovarian hyperstimulation syndrome and too many growth of eggs. So I guess a step-up technique, step-up protocol will be much better in those kind of patients. And the other thing would be considering doing ablative surgery, like laparoscopic surgery, laparoscopic ovarian drilling is an option where you can help to improve their response, okay, and also can give them an option of trying naturally in the first 3 to 6 months after the laparoscopic surgery. And if still they do not respond, do not conceive after that, then you can start off the medication, as I said, at a step-up protocol.
Okay. Is there any upper age limit for a woman going for IVF treatment? We all know that a woman with even advanced stage can conceive sometimes with donor eggs. But the medical comorbidities like diabetes, hypertension, or heart disease are more prevalent in this age group that may further complicate the pregnancy. So, what is your take on this?
Well, advanced maternal age. There are a lot of ethical issues surrounding this particular topic, and a lot of people have done all sorts of things, like patients above age of 60, 65, try to give them, put them through an IVF. So I think most importantly, most importantly, everybody should have a chance to have their own child, or rather to have children. And if they opt for pregnancy by themselves through donor eggs, then we should allow them. However, we should still ensure that the patient is healthy. Healthy means then, like if they have diabetes, hypertension, any comorbidities, we should have them be checked by the certain specialties in a multidisciplinary team approach to ensure that they are physically, mentally healthy and capable of having a successful pregnancy. And the other thing would be, I think there should be some form of age limits. For example, probably max 55 or so, because you should think about the child. The mother may not be around long enough to care for the child, to grow up with the child. So a 65-year-old running around behind a 3-4-year-old, I think that will definitely be very difficult for them. So I do believe that there should be a certain amount of age limits, probably, I would say about 50, at least 55 years of age. And before you put them through a surgery, there must be some stringent tests to ensure that they are physically healthy. That's what I would do. My oldest patient is 52 years old, and she thinks she can sprint 100 meters faster than I can. Okay, so she was physically, mentally, and healthy. So therefore, we proceeded in the treatment. But before that, this 2 months prior to the embryo transfer, she had to go through lots of tests and assessments with the physicians to ensure that she's capable of, getting pregnant.
Exactly. With advancement in vitrification techniques, the success of IVF with frozen embryo transfer has increased, such that many of the IVF centers are opting for more and more frozen transfers. So, would you recommend a freeze for all policy for all, or freeze for all only for PCO patients? I need to ask.
My opinion here would be I do not agree with freeze all um, policies. The reason being is that what were we doing all this while? You were doing a lot of fresh transfers, right? And we were still getting lots of pregnancies. Okay, so before any procedure has to be done, there must be a certain reason as to why we're doing something.
Yeah,
So
I
for
agree.
me, for me, if I were to opt for frozen embryo transfer, be it for a PCO patient or any patient for that matter, I follow certain rules. Firstly, pre-ovulatory progesterone level will be checked. I routinely do this. If it's elevated, then I would advise the patient to freeze all the embryos and do a frozen transfer 6 weeks later. Number
Okay.
two, during the ultrasound scans, as I'm retrieving the egg, if I see like fluid in the endometrial cavity,
Yeah.
that's another reason why you might fail a transfer. Then I would defer. Patient having fever, unwell, or overstimulated,
Yeah.
then I would rather defer the fresh transfer and do a frozen transfer. Okay, and talking about PCO patients, I've had PCO patients quite a number of times where I've done fresh transfers for them and they successfully got pregnant and delivered without any issues. So I still followed the same rules for them where I ensured they were not overstimulated because not all PCO patients will produce 30, 40 eggs. Some of them only get about 10, 15 eggs depending on your stimulation protocol. So if you use the step up option protocols, then you might not have an overstimulated PCO patient. So in my opinion, um, it should be it should be anything that we decide, whether fresh or frozen. There must be a reason why we are doing it. And I really don't believe in the option of freeze all technique. So in my practice, it's 50-50. Half my patients I do fresh and half with an indication. Okay, we do frozen. The other reason why I do frozen in certain patients uh, if they had multiple embryo transfer failures. So what I'll do is I'll do a certain endometrial receptivity analysis for them, okay, in a subsequent cycle after the retrieval. And once I get the results, then the next cycle is the third month. I'll do the embryo transfer.
Okay.
So these are my indications as to why I do a frozen transfer.
Okay. Uh, in IVF cycles, we as a clinician and our patient both are concerned, I would say rather obsessed with the success of treatment. Therefore, often it is seen that multiple embryos are transferred, which obviously increases the success rate theoretically, but at the same time increases the incidence of multiple pregnancy, which is not desirable. So, can you please share with what would be the best practices? What factors should be considered while deciding the number of embryos to transfer for a patient?
Well, um, I'm more in favor of single embryo transfers. Okay. However, I do have patients who still are keen for two embryos to be inserted in. One guideline or recommendation which I do follow is the NICE guidelines from the UK, where they mention that patients above 37 years of age, if they have a good quality embryo, to transfer one at a time, even if the second cycle, and the third cycle you may opt for two. The patients above age of 40, then you may consider putting one in if you have a good grade embryo, or two if you don't have top grade embryos. So gone are the days I put in three. I don't practice that anymore. But there are a few issues here. Number one, the patient side. For the patients, they have this view that, you buy one, get one free. You put one embryo, you get another baby, or two, for the price of one, you get two babies. And, they'll look at the Facebook pictures of neighbors, their friends who have twin babies, they look very happy, but they do not know what the lady had gone through. The carrying twin babies, the problems, she could not walk, could not breathe, could just have to lie down most of the time. The other thing is that I guess we have started to be fertility doctors too. In our Facebook, in all our marketing things, we show it. We have couples holding two babies, even us as doctors holding two babies. So we tend to project that having two babies is actually fine. And the other thing would be the cost implication for a patient. Money is not unlimited. So a lot of patients have invested a lot of their money, their savings in getting a baby. And due to budgetary problems, they might not be able to afford another round of frozen embryo transfer. Hence, they rather put everything into the womb at once. Some of them come in for 3. And as for doctors too, we do not want to be faced with a patient have failed the IVF cycle. So the idea about one embryo may be healthy and one embryo may not, so let's just put 2 in and see how it goes. Because then we tend to have this, what you call that, regret that no, we should have put in 2 in, then we'll have 1 baby. Example, we put in 1 baby, she doesn't get pregnant 6 weeks, or 2 months later, put another 1 in, she gets pregnant. Then you start thinking to yourself, maybe I should have put in 2 babies, and she could have got pregnant 3 months earlier. So, but then again, I think we should be logical in the sense that a woman is born with a womb that has been made to carry 1 baby at one time. Okay, putting 2 babies, you unnecessarily put her into risk, not only her but the baby too. So I'm in favor of putting 1 at a time, but in certain cases, I'll put in 2. So yeah, that's about it. So I think as doctors too, we should counsel the patients, explain to them that the risk of having twin or multiple pregnancies, risk of prematurity, ICU, neonatal ICU cares, miscarriages, severe preterm births.
All the complications.
All the complications should be explained nicely. So we have that in our consent form, like in our consent form before the embryo transfer. So anybody who puts in 2 or 3 embryos to be transferred, we give them this form for them to read and ponder about it for a while.
Yeah. My next question is about endometriosis patients, IVF in a patient with endometriosis. So is there any size of ovarian endometrioma for which you would like to go for debulking first and then IVF?
Well, I wouldn't look at the size only. I'll look at the patient's age, a previous history of any previous surgeries, cystectomies that were done previously, her ovarian reserve by a test called anti-Mullin hormone, and her current symptoms. So I'll look at all these things, and also the next would be the accessibility of the ovary when you want to do the egg retrieval.
Yeah.
If the ovary is fixed high up with adhesions and all, where the ovary is inaccessible, then what I would do is then I'll do a surgery for patients, which I'll only do surgery for patients if they have a very adhered high up ovary, or she has very severe, if she has severe symptoms of pain, dysmenorrhea, then I'll consider, or even patients with really huge endometriotic cysts which have not been operated before. It may be most of the time above 4 centimeters. Okay, but I would prefer to do least invasive procedures on this patient, because we totally know about patients. We have seen this day in, day out, where this patient has gone in for a perfect debulking surgery by a perfect, skillful laparoscopic surgeon, and they come back with a very poor ovarian reserve. then you'll be wondering whether or not, surgery was a good option for her. So lately, what I've been doing, lately means since a couple of years, I've started doing the long down regulation for the patients, where I give them these long mucilin injections, 0.5, from the 21st day of their cycle. I will down regulate them. Then I'll take them to the operation theatre, and I'll aspirate all these cysts. If they're not big, like probably about less than 4 centimeters, I'll aspirate all this under ultrasound guidance. And 5 days later, I'll start them on the gonadotropin injections. Then I'll retrieve the eggs later. By doing this, you avoid damage to the ovaries. You avoid them to have a low ovarian reserve, and they can still produce eggs, and you can retrieve the eggs without much of a problem. But you have to be aware that this procedure has a lot of the main problem with this procedure is infection, pelvic abscess. So before this procedure, I tend to give them 5 days of antibiotics and vaginal inserts, antiseptic vaginal inserts, 5 days before the procedure, and then I will clean it with some povidone before I do a transvaginal ultrasound scan and aspirate all the cyst contents. Mm-hmm. So far, by doing this, I've managed to prevent, rather to avoid any surgery for the patients, and a lot of them eventually got pregnant. The only problems we face is when patients with very, very adhered and ovaries which are placed above the uterus. Then you will have to laparoscopic surgery will be required in these patients.
Okay. Next, I would like to know about the laser-assisted hatching. What has been your experience of using this?
Laser-assisted hatching is something which we routinely use, especially for patients undergoing frozen embryo transfer. As we know, the freezing thawing process will have a very thick and times hardened zona pellucida. So by doing the laser-assisted hatching, either thinning out the shell or creating going through it, then that helps in implantation. Previously, we used to do it for patients. More than 10 years ago, we used to do it for patients with history of recurrent implantation failure. But now we use it quite regularly in our practice, and it's something which I think it should be part of the IVF service.
Okay. Now, for a couple with multiple failed IVF cycles, what would be your next recommendation? Like endometrial scratch or something else?
Well, first of all, we have to find out again why were they failing, and unfortunately, it's always unexplained. Mm-hmm. So there are two main things that I would do for this patient. Number one, I would advise them to go for a pre-implantation genetic testing to check for aneuploidies.
PGT, yeah.
PGT. In that ways, we can determine the best embryo for transfer. Secondly, there are many tests now available to ascertain the best time to transfer the embryo. After how many days of progesterone tablets we give them, how many days, how many hours after that, we can determine the best timing, rather the window of implantation for these patients.
You mean ERA?
Yes, ERA, endometrium receptivity analysis. Yeah. Okay, so this test has been known to increase pregnancy rates by 72.5% by checking the 240 plus genes in the womb lining. And I've been using this test quite some time already now, and I have found that it has definitely increased in the pregnancy rates, especially for patients with this recurrent implantation failure. And many of the patients that have undergone these failures before 2 or 3 times, I found that the window implantation was displaced either a day earlier or a day later. So these are the two main things. Thirdly, if you have to determine whether the cause of their failures, was it the sperm quality, is it very poor, or the egg qualities, especially in patients which are of advanced maternal age, is very poor, then you may have to look at the options of getting them either a sperm donor or even an egg donor.
Okay.
So these are the few things. The other thing would be considering giving them things like aspirin to help in the implantation, or even some form of steroids, prednisolone, a day or two before the embryo transfer. This is how I would treat. As for endometrial scratching, I'm not convinced. Okay, so I don't do that procedure in the luteal phase prior to the IVF. And I think last year I think in Ashra they presented a series of paper that was presented there, where they found that the endometrial scratching was not beneficial. Okay, so I've stopped doing that, and I rather stick to the more mainstream kind of practices like PGT and ERA, and to help my patients with multiple failures.
Okay. Now let us talk about oocyte preservation. What is your preferred protocol in patients with, say, young patient with carcinoma breast?
Well, I've had a few of these patients over the years where first I will send them to the breast surgeon, the oncologist, all for an assessment. Once they are ready, I prefer to use the antagonist protocol. And if they are young and a very good ovarian reserve, I'll give them a very low dose of erythrophits, probably 75 or 150, or max 200, and I'll add letrozole with it. It's 5 milligram once a day, and I'll try my best to start them on the IVF cycle as soon as possible before they go in for their chemotherapy. And the other cases that I've done where we had to do it for a patient with blood problems. She was about 38 years old, so we had to give her quite a high dose of gynecologist to retrieve as many eggs as possible since she was single. It's different for patients who are single and who are married, because in patients who already and who have a partner, then we can freeze the embryos instead, compared to freezing eggs. As we know, when we thaw out the eggs, a lot of them may not survive. So in single patients, then we have to give them a much higher dose to get as many eggs as possible.
Okay. At last, I would ask that what is your advice to a young gynecologist who is aspiring to be an ART specialist? How to go about training, how to go about lab setup, etc.?
Well, my word to them would be you have to be mentally strong, because because fertility line, we are dealing with a lot of healthy individuals who come to you for a hope of a life with a baby. You know, they coming to us with lots of aspirations, a lot of hope, you know, and a lot of investment. So there's a lot of stress to give them what they want, you see. So, and it's a roller coaster ride, because sometimes when you get failures, then you'll be like upset the entire day, and when you get a lot of successes, or the whole day, you'll be extremely happy and, you know, be nice. So it's a roller coaster ride for both the patients and the staff, not only the doctors but the nurses and the embryologists too. And as for training, it's no different compared to any specialty, where more you read, more you learn, more you do, the better you get. And fertility is one specialty where It's ever evolving every single day. You open when a new journal comes up, okay, a new um,
Study.
journal, then you get another new test or new treatment option coming out. So you have to quickly learn those things and keep abreast at every time about what the new technology is churning them out. So you have to keep up with the new technology. And as for training, currently there are many options to the many ways. IT, I mean, to the internet webinars. And as for training, there are many centers offering good training. There are many good centers offering a lot of good training. What do you call that? Curriculums, and in many universities, even private centers too. So definitely, there's no lack of places to learn this thing. But I think you have to be firstly mentally strong to face this roller coaster ride.
Thank you, Dr. Navdeep, for this interesting discussion. I'm sure our viewers have learned a lot from this session. I would also like to thank our viewers for attending and participating in this session. If you have missed any part of this, the archived version will be available once the live session ends. Thank you, everyone. Stay safe.
Thank you very much.